even though I'm on the bus.
Oh, you're doing his website? Are we supposed to get 10% of whatever he's paying you?
I'm here, aren't I? You've gotten 100% of my time. 90, sir.
Did you guys upload the show from last week with these two guys? And broadcast? You guys should get. It was an amazing show.
It hasn't been put on air yet on the website, but as soon as it does, we'll download it and upload it, of course.
Very nice, very nice, very nice.
Yeah, we're monitoring that.
Oh, dude, is that your office, man? It looks beautiful.
No, this is my home office.
Wow.
Who's that guy behind you?
That's a mirror. It's a mirror.
I'm just kidding.
And we're live on the air with Dr. Kasraeian, Ali Kasraeian,
Good to see you.
who is a really good friend of ours. He is one of the top urologists in the world, currently practicing in Jacksonville, Florida. But his reach is really global because he does a lot of general urology, but he does mostly a lot of second opinion prostate cancer. So today, I think we're going to have a really, really interesting conversation about prostate cancer and some of the new tests that we can order to see whether you even need surgery. Because to be very honest with you, when I started my training, everyone got surgery or radiation, but now most people are not getting anything. So it's going to be a great conversation. We're happy to have Kasraeian on, and you've probably heard us on his radio show several times, and he has been a proud supporter of the drive now for 4 years. Welcome to the 2017 Drive for Men's Health live webcast.
Thank you for having me on. I'm very proud of you guys for growing this to tour bus status. Congratulations.
Here, look, you want to see our tour bus right here? Everyone say hi, Dr. Kasraeian.
Amazing. Look at your staff.
Earl's driving. Hey, it's Earl. Earl is our driver. All right.
So let me ask you, who is driving the Tesla right now?
It's being towed right now.
Yeah, we're towing it right now. It's possible to reach as many people as we want to.
We compromised a bit. So in between, we're towing the Tesla.
We're going green. We're saving electric energy at the same time.
Wow, congratulations.
There's been a lot of prostate cancer. There's been a lot of changes in prostate cancer. Actually, prostate cancer was all the buzz again this year at the AUA because like MRI and different tests you can order. Plus, in the past 365 days, what has changed from a prostate cancer screening standpoint and from a treatment standpoint?
I'll tell you, from the big buzz at the AUA this year was that the U.S. Preventative Service Task Force moved us from a grade D recommendation to a grade C recommendation, which basically went from don't screen to see your doctor, basically kind of moving towards more of a talk to your doctor, really about the personalized risk benefits for screening. So it kind of opened the door for a discussion of personalized screening. So obviously, as a urologist that deals with prostate cancer a lot, my bias is towards having an open discussion with your doctor, which starts with the primary care doctor about the benefits of screening. It's still, in my opinion, didn't have as strong of a discussion about screening for the younger guys. All of us who deal with prostate cancer or with men have those guys in the 40s that show up with prostate cancer. I actually have a patient who has prostate cancer whose son at 38 got diagnosed with Gleason 7 prostate cancer. And that's scary, for Jamin's still in his 30s, for those of us in our 40s. Seizures kind of leading the charge towards.
Don't give away his age. Don't give away his age.
I'm in my 40s.
Approaching other ages. We got to be mindful of those things.
How old are you? 18?
Me, I'm hitting 21 now, so I can actually start drinking now. So I can hang out with you guys. So I think the key for this is to have personalized discussions with your doctors about the benefits of screening. And the nice thing about some of the things that are out there now is that we can be smarter about personalizing this and doing the right thing for the right guy at the right time. And that starts with screening. We actually have tests that allow us to make the PSA test better. Tests like the 4K score allow us to look at the PSA and cousins of the PSA and see if the PSA is elevated because of a prostate cancer that may be aggressive. which is exactly what we're trying to do. We can do an MRI scan that looks within the prostate and sees if there's a tumor, and we can grade it. The PIRAS score is a 1 to 5 score, which is very similar to the BIRAS score for breast cancer and the mammography standard. So we can look at that, and we can come up with personalized decisions of whether or not to biopsy, and we can make screening better, and we can be smarter. So we can make screening smarter.
So you mentioned 4K score. You know, my experience with that has been doctors are ordering it, and then I'm kind of left deciphering the abnormal results or the alarming results. So I want you to kind of clarify, when should it really be used? And, you know, the data that's on there, how should we as urologists interpret it? So not only patient education, but education for us as well.
So I think the challenge with this is, you know, obviously the company wants all primary care doctors to use it as the PSA. That would be the greatest thing in the world. But I think that's not necessarily how it should be used. I think the 4K score should be used in a circumstance where it can give you information that can be beneficial. So if someone has a PSA and an abnormal rectal exam, so for example, if someone in their 40s comes in with a PSA of 3, you repeat it and it's 3, and they have an abnormal rectal exam, the 4K score, you know, is not going to really change your mind of whether or not that guy is going to get a biopsy. You know, an MRI scan may potentially give you some benefit if you have a fusion platform, so you could do a better biopsy, you know, from that standpoint. The 4K score is a test that's designed to allow you to avoid an unnecessary biopsy. So if you think that that test is going to allow you to avoid a biopsy that is not necessary, someone who is 68 years old, they've had multiple biopsies in the past, and they come in and they don't want another biopsy, and their PSA has been relatively stable and it's making a little bit of a change, and they're trying to figure out what to do next, maybe a 4K score can give you some information where if it comes back and they have a 1% chance of having a Gleason 7 or higher cancer, maybe they don't need a biopsy. But if it comes back and it's a 25% chance, that's a guy that you need to do a biopsy.
And that's what I've been using it for, and it really has helped. I mean, the more information you have, it really helps make the patient decisions with the patients. I've actually been ordering it to PSA patients because I think when they come back, it's just more information. But from a screening standpoint, would you say there's a role for that test to be the primary screening tool, or is PSA still the best?
I don't think so, because it doesn't, imagine this. Is it a test that everyone who comes into the door gets a 4K score? I don't think we're there yet, you know, because most PSA tests that are obtained are going to be, you know, low. The majority of men who get a PSA test is going to be low. And I think, you know, one of the most telling and most prognostic of your future risk of prostate cancer that's significant is your PSA in your early 40s. So the big study that was done in Malmö, Sweden, that followed people's PSA for their lifetime, they went back and looked at that first PSA between 45 and 49. And if your PSA at 45 was less than 1, your risk of prostate cancer in your lifetime was very, very low. If you're average risk, you're not African American, you don't have a family history of prostate cancer. They actually did a follow-up study, and if your PSA at 60 was less than 1, your risk of prostate cancer was negligible. That's profound. So do we need to get a 4K score as the first test out of the gate? No. Use it as a complement to help you make decisions for someone whose PSA was a little bit elevated. And I think my dog here kind of agrees with what's going on.
Wait, so what is the recommendation now? Because I usually say if you have a family history, you should at least get a baseline PSA at 40. Guidelines say 45, or is 40?
To be honest with you, the guidelines they still don't come out of the gates and tell us much of anything in terms of what they're all over the place. And that's what's, I think, very confusing for urologists. I think it's very confusing for primary care physicians, and it's incredibly confusing for patients. You know, in my opinion, I think for average risk men, you know, that first PSA somewhere in the mid to early 40s is very, very important. I think if you have a family history of prostate cancer, especially if someone in your family has a prostate cancer earlier in their age, it's very important to get that first PSA. And I think 40 to 45 is a great age, and 40 is great. African American men have a very, very high risk of getting early prostate cancer aggressive prostate cancer, and they have an increased risk of having fatal prostate cancer. So catching that early allows us to catch the prostate cancer at a time where it's still confined to the prostate cancer, where we can catch it at a time where most of our other treatments are still curative, and you can have conversations about active surveillance and all the other things that we're doing right now, and have the same conversations that you have with anyone else that is of an average risk of prostate cancer. Men with a family history, similar conversation. You got to make sure that you catch the cancer early enough that you can have similar conversations about what to do next. You know?
Great. So 4K score is the new test. Are there any other tests out there that kind of help the whole process?
I think the multiparametric MRI is changing the game. It opens up the curtain of the stage and allows us to see what's going on behind, kind of like your tour bus here. It lets us see what's going on behind the Tesla. Very, very similar. We now see all the shenanigans that go on behind that make you guys look like superstars in front of the Tesla. You know, it's kind of like a sniper. You know, a sniper doesn't, you know, now they can open up the curtain and see what's going on, as opposed to taking the 12 to 14 darts and throwing them up and hope that you see what's going on within the prostate. You now have a target and you can directly go within the prostate and see what's going on there. It gives you confidence in terms of your negative biopsy. So if you have a negative biopsy, you're more confident that it's truly negative. And then if it's actually positive, you're more confident that your positive biopsy is telling you what's going on within the prostate. The other cool thing about it is if it's positive, you can do things like focal therapy. You can go and target the area within the prostate and target that area if it's a low volume, low risk, or intermediate risk prostate cancer. That's not quite a cancer that you can monitor with active surveillance, but one that maybe isn't as high volume of a disease that needs a radical prostatectomy or radiation therapy, like you were alluding to earlier.
Yeah. Things like proton therapy and CyberKnife and all those, do you think they'll gain popularity as time goes on? Because I know that was all the buzz when I was in training, and now, you know, for me, if they want something definitive, it's either surgery or radiation. I don't.
So if you look at, I mean, so if you look, you know, here in Jacksonville, we get a lot of advertising for proton therapy, which is just celebrating its 11th year. It kind of 2006 was when proton therapy kind of was all the buzz. Proton therapy is a form of radiation therapy which uses protons instead of photons, and is claimed to fame that it can stop on a dime. So for prostate cancer, it has not been quite as successful as some other cancers like eye tumors, brain tumors, certain spine tumors, some pediatric tumors, where it has less side effects. So for prostate, some older studies showed that it wasn't quite as curative, especially for high-risk disease. Some of the newer studies show that it's equivalent at best. A study in 2012 in JAMA showed that it had a higher risk of rectal side effects. So it's not quite as successful, and it's much more expensive. So it's about $110,000 to $120,000 for a therapy, where it doesn't have a better cure rate or a lower side effect profile. So it doesn't make much sense. That's why I guess the Wall Street Journal articles and the things like that. You know, CyberKnife is billed as radiosurgery, but it's actually a form of radiation therapy where they give a higher dose of radiation therapy with each therapy, so they can do it in a shorter period of time, about 5 days. It has a role, you know. It's a very elegant way of trying to give radiation therapy in a shorter period of time. For low to intermediate risk disease, some of the short-term studies around 5 years show that it actually has very good results, but it has a little bit of a higher side effect profile. So if you have someone who has a larger prostate, it may not be a great way to go. And we don't have long-term study results. We don't have 10, 15-year results, which for prostate cancer, if you have a low to intermediate risk disease, we could probably sprinkle holy water on you and you'll do fine for about 5 years, you know?
What about HIFU? I know you are or used to be a fan of HIFU. Is that still something that's gaining traction? I
think HIFU is gaining traction. It just recently got FDA approved in the States in October of 2015, after being a procedure that's been done internationally for about 15 to 20 years. I think HIFU has a role for those cancers that are in between active surveillance and radical therapies like the prostatectomy and radiation therapy. And again, I'm a fellowship trained minimally invasive surgeon. You know, I spent a year in Paris doing nothing but radical prostatectomies with laparoscopic and robotic techniques, which sees you, would send me emails on what to do not to look stupid at the beginning of my training. You know, so I owe him a big debt of gratitude. So I'm a prostatectomist at heart, but there are a lot of cancers that are in between that don't necessarily need a prostatectomy, and things like HIFU, where you use sound waves and ultrasound to destroy the prostate tissue, and things like focal therapy, where you just treat the portion of the prostate that has the cancer, allow you to preserve the portion of the prostate that doesn't have cancer, and the more prostate you preserve, the more function you preserve. And I think that's a paradigm shift very similar to the differences between the radical mastectomy and the lumpectomy with radiation therapy, but for the properly selected patient with the proper cancer that meets that criteria. It's not a Gleason 8 prostate cancer all over the prostate that gets focal therapy. I think it's for the right patient at the right time with the right disease, properly selected by someone that knows what they're doing, and accepting a risk that
knows what they're doing. That I would say that's the most. That's very important. I want to stress that.
That's the key.
I don't want to cut you off, but I want to stress that because, you know, you're going to see a lot of marketing material, you know, as patients. You're going to see a lot of information out there, but you have to be able to ask your physician, hey, how many of these have you done? You know, and what is your experience with this? Because at the end of the day, body of your life, and there's studies showing that if you go out and get a second opinion, you get better outcomes because you are that
Absolutely.
much.
Absolutely, and that's the key for this thing. Things like HIFU and these novel technologies are really operator dependent. People that are going to really jump on the bandwagon because it's a very, very elegant procedure. And prostatectomies are hard operations, and you know, not too many people do them. Not too many people want to do them because it's a lot of patient discussions. There's a lot of upkeep after the procedure until you get your patient back to normalcy. And so if there's a procedure that seems easy to do and patients really want to do it, a lot of people may jump on that bandwagon. So the key is finding a team that knows what they're doing, a team that understands the technology and why you're doing it. And the key for that is patient selection. So it's finding the right disease, the right way to do the procedure, and understanding for the people that are deciding whether or not to do this, that you're giving up a little bit of cure for a significant improvement in quality of life, and how to follow that to make sure that difference in terms of cure with quality of life is not significant.
Great information, Dr. Kasraeian. How can our audience find you?
I'm in Jacksonville, Florida, at KasraeianUrology.com. I'm on Facebook and Twitter, and you can always listen to us on The Conversation on WOKV in Jacksonville, WOKV.com. The Conversation Jax. I'm on Twitter at Ali Kasraeian or at Conversation Jax. You can follow me through you and all the amazing things that you do.
And Dr. Kasraeian is also the local health expert for several of the local channels, and he speaks on not only urology but everything health. So essentially a driver for men's health on a daily basis, just like we are, and we appreciate, you know, your partnership and your willingness to drive for men's health with us this year in 2017. Ali, thank you so much.
No, thank you for having me. This was fantastic, and both you and Siju have been great friends, and I'm glad that you guys keep doing this, and I look forward to helping you guys in any way I can, and enjoy playing around across this nation and getting men to see the light.
We're about to go do yoga.
Oh, very nice.
Yeah, we're about to go to yoga for the next hour, so tune in.
Congratulations on getting men to do yoga. Well done.
All right. Thanks, Ali. We'll
Take
talk to
care.
you, man. Appreciate it. Have a good night. Thank you.
Have a good night.
Thank you.